No,
Okay.
sir.
Sivathanu, I think, is ready to go.
Yes, sir. Good evening,
Go
sir.
ahead. Hmm.
My topic is local anesthetic systemic toxicity.
Hmm.
Loss is always a potential complication of regional anesthesia. It can occur by any routes of administration. It primarily affects the cardiovascular system and central nervous system. It's most commonly due to accidental intravascular ingestion or LA overdose. Its incidence of fatal loss is actually very low, but some minor clinical features are underreported actually. And how the loss happens? Its pathology. We know that local anesthetics bind to alpha subunit of the sodium channel inside the cell, which prevents sodium influx and stop subsequent depolarization and acid potential generation. Here, toxicity occurs when the local anesthetic systemically absorbed into the blood vessels and is inhibit many components of the oxidation pathway, and it affects sodium channels in the cardiac tissues, and sodium channels present on the thalamic corticoneurons. And these two organs are less tolerant to anaerobic metabolism. These local anesthesics can also block potassium channels, calcium, and the NMDA and cholinergic receptors, and also affect cellular metabolic process, which can all contribute to that systemic toxicity. All drugs can cause loss, but potency paralyzed cardiac toxicity. Example, bupivacaine, which has the lowest CC-CNS ratio, had a high cardiac toxicity potential. It blocks the sodium channel at a very small concentration of 0.2 micrograms, and it is done in that fast and slow fraction. And any route can cause loss actually, but peripheral nerve block is the most common, and even on topical application, the loss can happen. And what are risk factors? There's a patient risk factor. First, the extremities of age. Due to the decrease in the level of the alpha-1 acid glycoproteins in the extremities of age, there's a free local anesthetic level will increase in the system and again lead to loss. And the pregnancy is a risk factor because in pregnancy there's a multiple factors associated with it. There's a decreased alpha-1 acid glycoprotein albumin in the pregnancy, and there's an increased cardiac output in pregnancy which lead to increased absorption. And there's a epidural venous encouragement can lead to increased local anesthesia absorption. And there is a decreased pseudocholinesterase in the pregnancy, which can lead to increased ester toxicity. And it's a progesterone also increased sensitivity of nerve fibers to local anesthesia drugs. And there's a metabolic acidosis, hypoxia, hypercarbia can stimulate loss. And there's a carnitine deficiency, and there's an end organ dysfunction, especially cardiac and hepatic dysfunction. And it's a block site. The site with higher vascularity can increase risk of loss. That is from intercostal block, which is at the highest risk, which is greater than and caudal block, followed by lumbar block, and the interfacial plane block, and psoas block, followed by the sciatic block, finally the cervical and the brachial plexus block. And how to prevent the prevention of loss? First, first there should be an adequate precaution and monitoring before giving regional anesthesia according to ASTRA guidelines. And then they're controlling the local anesthetics volumes and dose. Total dose administered should be lowest dose required for the desired effect. Maximum dose of local anesthetic should be calculated according to the lean body weight. And the dose on continuous or repeated administration should be lowered. Addition of epinephrine to local anesthetics, it causes slowing of absorption by 20 to 50%. And there should be slow incremental doses, not a rapid doses. And aspiration before ingestion is mandatory. And there should be given test dose, that IV marker should be used. Here, epinephrine 15 mg with the local anesthetic, with an increase in heart rate greater than 10 per minute, and 10 per and systolic blood pressure greater than 15 millimeter mercury within 20 to 40 seconds, indication of intravascular injection. And to avoid some deep sedation and GA for early identification. And in a pediatric patient, the using of UST is highly recommended. And the clinical features. Onset is usually classically seen soon after the ingestion. First is a CNS excitation, followed by inhibition, and followed by CVS features. The CNS features, initially there is initially it blocks the cortical inhibitory neural pathways, which result in CNS excitation, the change in mental status, perioral numbness, visual changes, muscle twitching, seizures, which is followed by CNS depression, it's a coma and respiratory depression. And then the serious features comes, the tachycardia and the hypertension, followed by bradycardia, hypertension, cardiac arrest, arrhythmia. That is, usually the CNS features is more first arrives first, followed by the serious features. But serious features can present present alone also. We should be cautious about it. And and then the management is mostly ABC approach. First, there's always a rapid response, the key to management. Then there's a maintenance of oxygenation and ventilation, and there's a seizure management and the cardiovascular support. First, there's a rapid response. First, we used to stop the further ingestion or infusion of drug, and is call for help and lipid emulsion, and shift a crash cart for emergency. And then we have to maintain the oxygenation and ventilation to provide 100% O2 by face mask, or if intubation if necessary. Our goal is to prevent the acidosis and the hypoxia. And the seizure management, benzodiazepine is the first line of choice. And it is a midazolam, 1 to 2 mg we can give. Or if not, propofol can give an incremental dose. And if or tiopronin we can give. If not seizure control, we can give scoline and intubate patient. And arrhythmia, amiodarone is the first line of drug. And in case of cardiac arrest, the management is by ACLS protocol, except a few points here. Here the amiodarone is the drug of choice for arrhythmia, first line. And the dose of epinephrine should be less than 1 mg per kg IV. And don't use lidocaine. And vasopressor should not be used. And avoid calcium blocker and calcium channel blocker and beta blockers. And finally, the lipid emulsion. It's a mechanism of action. It's a 20% intralipid. It's a mechanism of action. Is not as a proposed mechanism of action is. It's a lipid sink. It lipid bind to local anesthetics and to remove from target organ. Many theories tell that the lipid is lipid emulsions carry local anesthetics from the heart and the brain and to distribute to other organs which detoxify it. The lipid emulsion has also the direct cardiotonic effect. And there are various forms of lipid emulsion available. The intralipid 20%, liposin 20%, and a neutral-lipid 20%. When to start a lipid emulsion? Actually, any sign exhibited in patient who received regional anesthesia, we can start a lipid emulsion as soon as possible. The dose of lipid emulsion, we give 20% intralipid solution. Dose less than 70 kg, 1.5 ml per kg IV based on lean body weight, followed by 0.25 ml per kg per minute IV infusion. If more than 70 kg, maximum bolus dose is 100 ml IV for 2 to 3 minutes, followed by 250 ml IV infusion for 15 to 20 minutes. We can repeat the bolus and infusion if CV stability not achieved. Maximum dose is around 12 ml per kg. Propofol not a substitute for lipid emulsion. And it's a final management. First, we should stop the injection or infusion, call for help and lipid emulsion. While stabilizing the patient, arranged for cardiopulmonary bypass and airway management, ventilator with 100% O2 and prevent to hypoxia, hypercarbia and acidosis. And is manage seizure, manage cardiac arrest, and finally lipid emulsion. Institute a cardiopulmonary bypass for last and responsive to lipid emulsion or ACLS. And monitor the patient for 2 hours after seizures and 4 to 6 hours after hemodynamic instability. Thank you, sir.
And another important point is incident reporting. If such complications happen,
Yes,
it
sir.
has to be reported to the authorities and documented. Very,
Yes,
very
sir.
important.
Yes, sir.
Yeah.
Yes, sir.
So all the other points we have nicely covered.
Yes.
If they